Good morning, all of you, and it is my present duty on behalf of the Board of Education, Urological Society of India, to welcome you all this morning in this pleasant city of Manipal. In fact, the BOE USI had been contemplating about starting this course for quite some time, and it has finally happened. So today it is, I think, one of the first things, this kind of course, as you all know, is the first ever kind of course which we have been doing with the Urological Society of India. And I thank Professor Paul Abrahams. He doesn't need any introduction. You have all read his books, his publications, and the various contributions. He has been a regular visitor to India. And so I think there are faculty members. This is today is the starting day, the first day, which will be a course dedicated to only the 20 candidates from all over the country, who are all consultants basically. And then tomorrow and onwards we'll have 2 days course. So I think you all are going to enjoy the entire feast. And may I invite Professor Paul Abrahams to start the innings. Thank you.
Thank you very much. And then I will be asking you questions. And this is the course that we're. Where's Anishka? Yeah. The course that Professor Chawla, the USI, and I've devised is really a modification of the certificate course, which is the certificate course that we do is usually 2 days. But we are doing the clinical parts, as you said, on Saturday and Sunday. So today is really about the technique of urodynamics. And you will quickly realize that this is central to the whole issue of managing lower urinary tract dysfunction. Because if you can't do the investigations properly, then you can't manage the patient properly. So you are all relatively experienced. For our certificate courses, usually people are less experienced and less expert than you. So we would like some feedback at the end of the course. So you tell us whether we have got the level correct, or whether it's too easy or too difficult. I hope it won't be too difficult. And you must, because I'm going to ask you lots of questions, I expect you to ask me lots of questions. So feel free to interrupt and ask. If you don't want to interrupt, write down the question, and then we can deal with it later on. So I hope that's okay. Good. Well, it's a great pleasure to be here, and many thanks to USI and also to Professor Chawla for asking me to come to this wonderful place. And I think I would like to work here. It's such a beautiful campus. And the birds and the flowers and the trees are very special compared with England, where it's quite nice weather at the moment, but it's only 11 degrees. So I have to wear lots of clothes. Here, it's fantastic. So this is, everybody needs a minder. So I'm old and he's young, and he thinks I forget everything. So he reminds me, but he's very polite, and I'm very grateful to you. Thank you. And he's shown me around the area, which has been very good. Okay, so let's start. So I come from Bristol, and this is, we're very lucky we've had a new hospital, which I think you agree looks a bit like an airport terminal. But the patients like it. The doctors are not so keen because we used to have offices. And now in the new world, we have an office, but it's like this room with about 30 people in it, which is not really an office, is it? So I would urge you, if you are ever, when you become consultants, those of you who aren't consultants, you should say, if you want to do academic work, research or teaching, you need some quiet space. And a big open plan office, for me, is crazy. So, but otherwise, the patients are nice, the patients love it, and it works on an airport system. So the developers said, we are going to guide the patient by using gates. So urology is at gate 36, and it worked very well. They said everybody in Bristol has travelled by aeroplane. Well, I'm sure that's not totally true, but most people have. Most people understand what gates are. So rather than have names, we have gates, and patients don't get lost, which is good. Now, what I want to emphasize is that lower urinary tract function and urodynamics is not really very complicated. And you need to keep the simplicity in mind. If you keep the simple things about the lower urinary tract in mind, then you can work everything out, as I'll explain as we go along. There are some little bits which are a bit more complicated than others, but overall, it's pretty straightforward. So you have to think about what you want. So you want a bladder, which is a reservoir, and there's a prize for anybody who can identify all the places in these slides. So you want a bladder that's a reservoir that empties with a good flow and empties to completion. And you all know the complications. Sometimes you have bacterial overgrowth with recurrent cystitis if the bladder doesn't empty properly. And you see this much more often than I do, stone formation. Stone formation in England, of course, it occurs. We have a lithotripter, we have endourologists who are very skilled at getting stones out, but we don't see as many as you do because of the differences, mainly, I think, in temperature and climate. Now, we have a famous engineer from Bristol who lived in the 19th century called Isambard Kingdom Brunel, and he would have said that in engineering terms, form follows function. So from our point of view, that means anatomy follows the necessary physiology. So if you know what the essential physiology is, which I just described to you, then you have to design a system that allows that physiology of filling and voiding to be carried out efficiently. So this is the female lower urinary tract, detrusor, urethra, and pelvic floor. So you can see that the muscle arrangement in the detrusor is intended to show on this diagram that the muscle goes in all directions. Well, if you think again about design, and you want something to go from 300 or 400 mLs down to 0, then you have to have muscle going in all directions in order to have that change in configuration of the bladder. So that's understandable. If we come to the urethra is a tube, just like all the other tubes in our body, and all the other tubes in our body have layers. So the urethra has layers. But you can see there's no real continuity between the detrusor and the urethra, with, of course, the exception of the trigonal muscle, whatever that is for. We don't really know what the trigonal muscle does, do we? We assume that the trigonal muscle contracts at the time of micturition and it pulls the ureteric orifice medially, therefore making reflux less likely. And perhaps also, if it contracts in the vertical sense, because the trigonal muscle is the only muscle that goes across the bladder neck to the mid-urethra in the female, and obviously to the veru in the male. So that crosses the bladder neck, and perhaps it helps to funnel the bladder neck when you come to void. But otherwise, the urethra and the bladder are separate from a muscle point of view, but of course from the neurological point of view, it's very important that they're connected properly so that the bladder and urethra work together, and we'll come to that. So the urethra has an inner longitudinal smooth muscle, and then it has an outer circularly arranged, what sort of muscle is that? Striated muscle, so that's really unusual. What other muscle in the body has a mixture? What other structure in the body has a mixture of smooth muscle and striated muscle? I don't think so. You're changing your esophagus, don't you? But I don't think it's mixed in the same way as this is. So they work obviously in a different way. And the pelvic floor is of course separate, and those of you that have been in radical prostatectomy know that this is the case. So I'm going to ask you then about running, because I know you're an athlete. So tell me about the different types of striated muscle fibers. You use there's a microphone behind you. What are the different types of striated muscle fibers? Do you remember from your physiology? Anybody? Fast twitch and slow twitch. So if you were Isambard King Brunel, the famous engineer, what sort of muscle fibers would you put in the striated sphincter of the urethra? Slow twitch. Did you say?
Yes.
Why? I agree, but why?
Has to stay
Maintain contraction.
You have to use the microphone because I'm deaf.
Sir. That needs to be active long so to keep the urine from dribbling down, that is to maintain continence.
Yeah.
You need to have slow this.
And what type of striated muscle fibers would you put in my biceps?
Fast action.
Yes, because I might want to punch you.
Yes.
I was brought up. I think evolution's really interesting, and we pretend we're civilized, but we aren't. We're no different to the men and women who lived 10,000 years ago, who couldn't read or write and barely could communicate. Our brains are exactly the same. So, fighting's very important, and I need fast twitch fibers, but you're quite right, I need slow twitch fibers in my urethral sphincter because I need to contract it for hours. And hopefully you can all do that, but if some of you have a weak sphincter, then the bathroom is through those doors and on the right. But hopefully you don't. So that's a very important consideration. And in fact, the pelvic floor also has a high proportion of slow twitch because this is one of the muscles of postural stability, the pelvic floor. It's what allows us to stand upright. So the pelvic floor is important because it stops everything falling on the floor. Whereas a dog or any animal that's on all fours does not need a strong pelvic floor like we need a strong pelvic floor. And the other muscles of postural stability are the transverse abdominis and the muscles along the spine, the small muscles along the spine between the vertebrae. And we'll talk about those as they're very important tomorrow. So there are really some quite unusual aspects of the design of the lower urinary tract, which if you think about it, are absolutely essential. Now, this is the female urethra. So these are the pubic bones in the front, this is a cross-section, and here is the vagina. And the first thing you can see, of course, is how far is the urethra from the vagina? Not very far. Which, of course, accounts for the problems that women have after childbirth, because once the baby's head has been through the vagina, of course, the urethra is really flattened. So from going from that, it becomes a slit, and it becomes a wide slit. And you can see here that here is our external circular striated muscle. And you can see that it's relatively deficient posteriorly. And this is a diagram taken from a woman who died at the age of 60 who'd had children. So if you had had her urethra to examine when she was 12 and had had no children, then she would have had more muscle posteriorly. So in incontinence, we see that the muscle, which is next to the vagina, is relatively deficient. And of course, many of our patients not only have urinary incontinence, they also have fecal incontinence. Again, this may be secondary to childbirth. And if you look at the anal sphincter down here, okay, you won't be surprised that it's the anterior part of the anal sphincter which also tends to be attenuated after childbirth. So we see good anatomical reasons why women, although they have the privilege of having our children, they do have this disadvantage of risk in developing problems because of the vagina being so close to the urethra and so close to the anal canal. So in addition to the circular striated muscle, we've got the inner longitudinal layer of smooth muscle, and then you've got a rich plexus of veins, submucosa, etc. And of course this tends to change after the menopause and become relatively atrophic compared with before the menopause, and we'll be talking again about that tomorrow. So there are these anatomical differences between the male and the female. Obviously the female urethra is straight, short. The male urethra is much longer and goes through a couple of significant bends, and has the prostate there as well. So when you look at a video of the lower urinary tract, the female urethra often looks very wide as the woman is voiding, compared with the male urethra, which looks narrow. The sphincter, as we've said, particularly after childbirth, is more horseshoe-shaped, meaning that actually the resistance to flow in the female urethra is going to be lower, just because of that. And in the male, the sphincter is more circular. So the effect of this anatomy is that when the woman voids, it's much more efficient. And the flow is called laminar flow in hydrodynamic terms, which basically means if you looked at it under a microscope, it's all in parallel lines. Whereas the male flow is turbulent, like a stream running through a rocky valley. So at the middle, it's parallel flow, it's laminar flow, but at the sides you have turbulence. And turbulence is inefficient. You lose energy. And therefore, the woman, to achieve a flow rate, has relatively low pressure. The male, to achieve the same flow rate, has to void at high pressure because the outlet resistance is higher. So always in urodynamics and thinking about patients, we're thinking about the combination of the detrusor contraction against the outlet resistance during voiding. And that's the key to a lot of our management. Now the other thing that's a bit unusual about the urinary tract is that it has triple innervation. Where's our, oh, it's gone over there. Okay, so what do I mean by triple innervation?
It has a parasympathetic supply, sympathetic supply, as well as
Parasympathetic,
sympathetic, and it has a motor supply.
and it has and somatic. Good, well done. So all three parts of the nervous system that we all have are represented. So let's just go through the innervation. So here we've got the afferent fibers coming from the bladder to the sacral cord and relaying up along the spinal cord, pontine, Victrician center, and up to the brain. Then, as you say, we've got the somatic, which is motor, of course, and it's motor in the bits we're interested in are the pelvic floor, and in men, some to the prostate area. So that is in the pudendal nerve. Okay, so that's the somatic. And then we've got the sympathetic, which of course comes out from the lumbar cord, not from the sacral cord, and supplies, we now know of course it's important that it supplies the whole of the bladder. Which drug exploits that? Which drug exploits the fact that we now know there are important sympathetic fibers to the detrusor muscle? Mirabegron, quite right. So that's a beta-3 adrenergic agonist. So we know how important that is because that drug actually works. So not only does it supply the bladder neck area, it also supplies the detrusor and of course the prostatic smooth muscle, but it also sends down small fibers onto the parasympathetic ganglia. And then finally we have the parasympathetic, which is of course motor. In other words, it makes the detrusor contract. So if we put all that together, this is the filling phase. So in the filling phase, we're getting information coming from our bladder, which is being relayed up eventually to our brain. But fortunately, we don't know that our bladder's filling. And imagine how irritating it would be to know, well, I've just been to the bathroom now, because I can't go out in the middle of the lecture. So imagine I've got 10 or 20 mLs in my bladder now. How irritating it would be to feel that I had 10 or 20, that I had 30, 40, 50 to 60. So the brain's very clever, the system's very clever. It shuts out all that information until our bladder's about half full when we get a first sensation of void. But if we're doing something interesting, that goes away. And about 3/4 of bladder capacity, then we get a normal desire to void when we would normally go at the next reasonable time. And of course, the further you go, the more uncomfortable you get. So that's a very good system. So what do we want the bladder to do during filling?
We want the bladder to be quiet. We want the...
Can you use a more scientific term? Quiet means that the bladder's not shouting. So I know exactly what you mean.
it has to be receptive, relaxation should be there.
The bladder has to be relaxed. Now this is really simple stuff, isn't it? So I know you know all this, and actually if you sat down with your father, mother, brother or sister, they could probably tell you exactly the same things. But people forget how simple it is. And when you're teaching the students and the young doctors, it's really important that you make it really simple. Because if you define normal function, then it becomes very straightforward to define abnormal function. So you want the bladder relaxed and the urethra
To be contracted to
you
make
want the urethra contracted. So have we achieved that here? Well, let's have a look. We've got our pudendal nerve, and you can see the pluses there. So the pudendal nerve is stimulating the striated muscle of the pelvic floor and the circular striated muscle of the urethra, keeping the urethra contracted. Here is our motor supply to the bladder, the orange one, parasympathetic, and that is now switched off. And that is helped by these inhibitory fibers from the sympathetic. So the sympathetic is interfering with the parasympathetic, which is what we want. So the detrusor will therefore be relaxed. And of course there, the sympathetic is part of the fight and flight reflex, isn't it? So if you go back to our evolutionary terms, and we were all brought up, weren't we, in the Olduvai Gorge in Kenya, in Central Africa, East Africa, where we lived in a pretty hostile environment. There were lots of lions, no tigers of course, but leopards and other difficult animals. And so we would from time to time not win our battle and we would have to run away. So the last thing we would want to do when we're running away is to leave a trail of urine or a trail of feces. Because of course lions have extremely good sense of smell and they would find us and eat us. So evolution is really important, and the sympathetic fight and flight protects us. So in our situation, it's protecting us at this minute. You know, it's inhibiting our detrusor, and the somatic is keeping our urethra closed. So that's essential for fulfilling. And then when we come to voiding, this is getting really tough now. What do we want now to happen?
During voiding, first the sphincter relaxes, then the detrusor contracts.
And that's important, he said it like that, because there's not much point in the detrusor contracting first if the sphincter isn't relaxed. So the sphincter, we decide when we want to void, we send out messages in the pudendal nerve for the outlet to relax, and in the parasympathetic for the bladder to contract. Now, when you go to the bathroom, do you say, sphincter, please relax now? Okay, bladder, please relax now.
No, sir.
So why does your sphincter relax before your bladder contracts? Can you think of a reason? Because we presumably decide at the same moment, don't we? So why would the sphincter relax first?
So autonomic, sir.
Sorry? So what is the nerve supply to the sphincter, the bit that we're interested in?
Duodenal nerve, that is somatic. Duodenal nerve.
Somatic, good. And it's striated muscle, right. And the bladder is
Smooth muscle, sir.
smooth muscle, okay. Is there a clue there as to why the sphincter relaxes first?
It is under voluntary control, that is not.
Well, they're both under voluntary control, aren't they? You see, the whole thing about voluntary controls are nonsense, isn't it? We always think that everything that's smooth muscle is not under our control, but that's rubbish. Because we can decide when to defecate, we can decide when to micturate. So obviously, smooth muscle is under some degree. Now, I can't stop my bowel from peristalsing as far as I know, but I'm sure there are Hindi mystics who can. I don't know any of them, but there probably are. So why does the sphincter relax before the bladder contracts?
Somatic nerves are faster.
Partly to do with inhibition of the guarding reflex. Partly to do with inhibition of the guarding reflex. And
Well,
partly
that's complicated. Don't be complicated.
Somatic nerves.
It's really simple.
smooth muscle.
Somatic
Okay,
nerves
smooth
transfer.
muscle.
It relaxes.
No, we're asking our smooth muscle to contract, not to relax.
Smooth muscles are slow twitch and.
It's slow. Yeah, it's slow. Smooth muscle's slow stuff. You see, I can do that instantly, but I can't now instantly pee. Thank God. Otherwise, I might be tempted to show you. But no, it takes 5 or 10 seconds to get your detrusor to contract. So, with the same impulse from your brain, the striatum muscle will relax immediately, and then the detrusor will build up pressure. So that works perfectly, and you get what you want. You get your sphincter relaxing before your detrusor contracts. Okay, so this is really, I think, explains the point of the triple inhalation. And I show this to you really because when we see patients in the clinic, and when they're referred for urodynamics, then we see problems, don't we, right from here, right to here. So what's the commonest condition up here that we see where patients have problems with their bladder? What's the commonest?
Cerebral accident.
Sorry?
CVA, cerebral accident. In CVA there is commonly there is
What condition is it?
cerebral CVA, sir, stroke.
Stroke. Excellent. Yes, that's commonest. So in stroke, do patients micturate normally? I know they micturate. I know they can micturate when they shouldn't, but is the actual micturition process normal in a stroke patient or not?
In stroke patient, then normally there is overactive symptoms are more.
Yeah, I know that, but is the actual micturition normal? It's at the wrong time, but is it normal?
Yes, sir, it is normal, sir.
Yeah, it's
That's
normal.
inside normal.
It's normal, that's correct. So the urethra relaxes, the bladder contracts, maybe at the wrong time, but it is a normal process. So what is the significance? I mentioned the Pontine Micturition Center. Does anyone know the significance? What's the function of the Pontine Micturition Center?
So it gives the orders properly like that. It first gives the orders for the striated muscles to relax and then for the bladder to contract. So that coordination
Good,
comes from the
yeah.
Pontine
So it's the coordination center. It makes sure that the urethra does relax before the bladder contracts. Okay. So if you have a spinal cord injury below the Pontine Micturition Center and above the sacral micturition center, what condition may you have? Do you know the name of where there is lack of coordination? Can you pass him the microphone, please?
Automatic.
Yeah, you could call it that. No, there's a. Anyone know the term? Detrusor sphincter dyssynergia. Okay, so that tells you detrusor sphincter dys means not coordinated. So they're not coordinated, and of course, what that in practice means that when the bladder contracts, the sphincter also contracts. Not a good idea. So when you have had a stroke, when you had a stroke, then your micturition is normal, it's coordinated. It may be at the wrong time, but it's still coordinated, so it's not dangerous. But if you've had a spinal cord injury or some other problem between the Pontine Nutrition Centre and the Sacral Nutrition Centre, you may have this detrusor sphincter dysynergia. Why is it dangerous?
It causes some high pressure.
There is a buildup of pressure in the bladder, and
Okay, tell me about pressure in the bladder. We haven't covered that. So what do you want the pressure in the bladder to be when the bladder's filling?
it has to be a low pressure during the filling.
Well, the detrusor's relaxed, isn't it? So it should be a low pressure. Why does it have to be a low pressure? There are two real reasons.
To prevent upper tract injury.
Well, why can't the upper tract just push harder? If the bladder pressure is a bit high, why can't it just push harder to get the urine into the bladder? Well, there are a couple of reasons for that. The ureter rather, is pathetic, isn't it? You look at a ureter, that can't do anything really. It's so thin. Even in a big ureter, a dilated ureter, the wall is still thin, so it has no power. But actually, we also depend on a pressure gradient, don't we, for renal filtration. So if the urine side pressure goes up, we can't filter the urine. So that's why we have to have low bladder pressure. Otherwise, we can't have normal renal filtration. So that's one reason. The other reason is that if your pressure was continuously going up in the bladder, you'd have to have some clever sphincter mechanism which increased the sphincter pressure so that we didn't leak all the time. But primarily, if again in evolutionary terms, if somebody had designed a high pressure bladder, then none of us would be here because we would all be dead from renal failure. So that's the danger, and obviously in detrusor sphincter dysynergia, over a period of time, then your detrusor can hypertrophy, become thickened, and then it can't relax properly because it's too thick. It's just a physical thing. A bit like when I hope bodybuilding's not as popular here as it is in the Western culture, but you sometimes walk behind somebody who's obviously been going to the gym and taking anabolic steroids for 10 years, and they can't really walk properly because their muscles are so big. Well, the bladder's a bit the same. So it's like going to the gym if you've got detrusor sphincter dysynergia because your bladder's spending a lot of time contracting against the bladder sphincter. So do you think that obstruction causes detrusor hypertrophy? Okay, so how many minutes are there in the day? How many minutes are there in 24 hours? Nobody ever knows this, and I can remember it now, but it took a long time. How many are there? Mental arithmetic, quick. 24 times 60. 24 times, do some mental arithmetic. Okay, well, it's very hard mental arithmetic. We used to be able to do it when we were young, but now it's pretty tough. The only people I know who can do it are in darts. Have you watched the people in darts? And there's a man who says how many they score, and they can do it instantly. Well, it's 1,440 minutes in 24 hours. How many minutes do you spend passing urine a day?
Hardly less than 1 minute.
Sorry?
Each time I pass urine, it takes less than 1 minute.
Less than 1 minute. Okay, so how many minutes? How many times do you go in 24 hours?
So usually.
Can you hear him? I can't hear it. They want to know how many times you pass urine in 24 hours. Is anyone prepared to say it here? 6. Well, 4 to 6. Shall we say 4 to 6? So you spend 5 minutes, let's say, and you're a bit slow, I'm afraid, because a minute's a bit long. Most people pass urine in 30 seconds. So you spend like 3 or 4 minutes a day passing urine. You spend 1,437 minutes not passing urine. Does obstruction cause bladder wall hypertrophy?
Actually, it's a chronic obstruction that causes that.
Well, you know why I'm asking this question. Why would obstruction cause hypertrophy if you're only, when you start getting your prostatic obstruction, which I hope you don't, but you might do when you get older, then is that really a potent cause? But you can see why detrusor sphincter dyssynergia is, because these patients take ages to void. And they also have detrusor overactivity as well. So I would argue that detrusor overactivity, even in neurologically normal patients, is a much more potent cause of detrusor hypertrophy, because your bladder spends a lot of time contracting. So I just digress in that. One of the things that we, as an academic, you're all academic people, aren't you? Yes. Now I forget, that in Indian means yes. So when you do that, I think no at first, and then I remember. So, are you all academics?
Yes.
No, please not in the Western way. Of course you're all academics. Anyone in surgery sitting in this room who says they're not an academic needs to leave medicine. Because academic means you think about things like this, which are important to understand in order that you can give good patient care. So yes, I think we need to challenge the uromythology. So one bit of uromythology is that bladder outlet obstruction is a potent cause of detrusor hypertrophy. Okay, well I would challenge that. I would say a much more potent cause is detrusor overactivity, just on the straight time. You would never go to the gym for 3 minutes a day and expect to get big biceps, would you? You've got to spend, I don't know, half an hour a day. A lot more than 3 minutes. Okay, good. So we spent rather a lot of time on this, but I think it's important. So turning then from the sort of anatomy to the physiology. So we've said we want detrusor relaxation, we want continuous urethral closure. Remembering that if you do go to the gym, and like one of my sons can lift huge amounts, when he lifts huge amounts, then his bladder pressure becomes very high. So what dictates whether you're dry or wet in terms of bladder and urethral pressure? So when he lifts 200 kilos, I can't remember how much he can lift, but it's more than 100 kilos. So what happens to his bladder pressure when he lifts 100 kilos?
Is P detrusor. Is it the P detrusor or the P vessel?
No, I asked you what happened to his bladder pressure, not what happened to his detrusor pressure.
His bladder pressure would increase in proportion to the abdominal pressure.
Yeah, and the abdominal pressure would increase in proportion to how much he lifts, I guess. Not that I think this study has ever been done, but there you are. You've got this great gym here. You could do some studies and just look at weightlifters and how high their pressures go. It's relevant because there's work showing in female Olympic athletes that they have stress incontinence. And that is, they've not had children, and that's because obviously female anatomy doesn't allow such good pelvic floor support, even if you haven't had children. So they get stress incontinence. As far as I know, male Olympic athletes don't get stress incontinence. So that goes, so what dictates whether you leak in terms of urethral and bladder pressure?
An abdominal leak point pressure of more than 60
No, I'm asking you a generic question. In terms of pressures, what dictates when you void then, or when you leak? What has the bladder pressure has to be
Vesical
Above
pressure has
the
to be
urethra.
above the urethral pressure.
exactly. So we've got to have continuous urethral closure, even if. So for sake of argument, my son's bladder pressure is probably about 40 centimeters of water, but I'm sure when he lifts big weights, it goes to 100. His resting urethral pressure will be about 70, so if his bladder pressure is 100 and his urethral pressure is 70, he's going to leak, isn't he? Well, as far as he's never told me he leaks, and I'm sure he doesn't leak. So you have to have a mechanism which allows that, and that's very important. Well, if we look at detrusor relaxation, muscle relaxation, of course, occurs at the end of voiding, but the bladder pressure is very special. Does anyone remember Laplace's law? Well, you did learn it, I think, once, but it was probably a long time ago. And that says that pressure equals twice tension divided by radius, which means that when your bladder increases in size, the pressure, the tension goes up, and therefore P equals 2T over R. If tension goes up, pressure should go up. Well, we've just said you can't have that. It's not allowed. And the way it works is that the detrusor has this thing called viscoelastic property. And essentially, the detrusor, when it relaxes, it doesn't just go into a shorter length. It actually goes, it's like a concertina. So that then when the bladder expands, it can expand without increase in tension, which is essential to keep P, if you go to P equals 2T over R. As long as tension doesn't go up, pressure won't go up. So because of the way the detrusor is designed, is that you couldn't do it if it was your biceps, for example. You couldn't. If you stretch the biceps, the tension would go up, and if the bladder was made of biceps, your pressure would go up. So that's a very clever mechanism, which is special for the bladder. We've already said that the sympathetic has these inhibitory nerves which interfere with the parasympathetic. And then the last thing, which you may still see more than I do, is that if you have patients with a lot of fibrosis in the bladder wall, then you see poor relaxation abilities because there's too much fibrous tissue. And I saw this when I started my career in urology, looking after urological patients who were not properly looked after in those days, who were having repeated serious urinary infections where the bladder wall became scarred and used to cut through it. It's like sometimes it's like cutting through. And I guess you get that with conditions. You get that with tubercular cystitis, which you still see sometimes. Yeah. So there are some conditions which you might still see. So we assume normal bladder wall composition that the detrusor is not too thick, and the bladder wall is made up of detrusor and not fibrous tissue. So we maintain our urethral closure during filling by the bladder neck, but we all know, don't we, that the bladder neck's not that important. Why do we know that the bladder neck's not that important? Because we do nasty things to the bladder neck, don't we? Routinely, regularly, every week in this department, in this hospital, I'm shocked to say that people cut the bladder neck. Doing what? Doing a TURP. You cut the bladder neck. Are all your TURP patients incontinent in menopause? No. So you don't need a bladder neck, really. And if you look at videos of women, postpartum women, postmenopausal women, 50% of continent women have an incompetent bladder neck. So women don't need it either. So that's not the main continence mechanism. But in young men, it is. It can be a continence mechanism. In other words, somebody did a clever study where they did pudendal nerve injections with local anesthetic, and these young men were still dry. So they paralyzed the striatal muscle sphincter, and they were still dry by their bladder neck. But as you get older, growth goes down the leg. And if you're a Hollywood star, you need plastic surgery every 5 or 10 years, or Bollywood star, should I say. Probably a Bollywood star too. You need plastic surgery. Well, it's the same with our bladder neck, because the bladder neck has quite a substantial amount of elastic tissue, which causes the bladder neck to close and provides some support. But nevertheless, we don't need it for continence. You've all seen radical prostatectomies, and you've all seen patients who are stress incontinence, I guess, after radical prostatectomy. And they have good pelvic floor contractions, because by the time you realise that their incontinence is not going to improve, they've been practicing pelvic floor exercises for months. So they're really good at pelvic floor, but they're still not dry. So of course, our main mechanism for continence is the intraurethral circularly arranged striated muscle sphincter. But there's lots of other mechanisms which help with urethral closure. I've talked about the elastic tissue. Postmenopausal women tend to lose good quality mucosa, and they lose some of the submucosal tissue with estrogen deficiency. One assumes that the inner longitudinal smooth muscle during filling is relaxed because it's smooth muscle, and then perhaps during voiding, if that shortens, it's effectively pulling the trigone and the mid-urethra closer together, and therefore it's probably shortening the urethra and helping the bladder neck to funnel. Now I say probably because it's impossible to investigate that. You can't get a needle into, well, you probably could get a needle into the trigeminal muscle, but nobody has ever managed to record the EMG of smooth muscle of the bladder. Contraction of the intraurethral striatum muscle, very important during filling, as we've said, and also the support from the pelvic floor and the endopelvic fascia. And then there's the mechanism of transmission of abdominal pressure. So looking at very simply, what we see here is the pelvic floor, the proximal urethra, the sphincter and the bladder. And this explains why my son doesn't leak, because the first part of the urethra is within the abdominal cavity. And by the laws of physics, in a cavity, pressure acts in all directions. So there will be a pressure that's trying to open my son's bladder neck, but there's an equal and opposite pressure that's squeezing it. Okay? And the problem after childbirth is that the pelvic floor is weakened, and therefore there isn't the support for the bladder neck. So the vertical pressure here has a big advantage, and the sideways pressure here is less efficient. So that's the passive mechanism, and that's known as a flutter valve, and we have that in a urine drainage bag, don't we? If you look at a urine drainage bag, the tube that comes into the drainage bag has a thin bit of plastic over it, hanging over it, which means if the bag is full, then the urine squeezes and stops the urine going back up into the patient's bladder. It's one of the first protective mechanisms that was ever made. And if you turn this upside down in the body, what do you have?
G junction. Gastric.
Yeah, you have the esophagus and the stomach, and the condition there is hiatus hernia. Exactly the same. So the principles of hiatus hernia surgery and urethral surgery for stress incontinence are identical. Now looking at it a bit more sophisticatedly, and this is John Delancey, who's a gynecologist from Ann Arbor in Michigan. I don't know if he drew it, but anyway, I got it from him. So this is looking at the right side of the pelvis, and you can see here is the urethra, bladder neck, bladder's removed. Here is the vagina with the uterus removed. This is the right side of the pelvic floor, cut away. This is part of the endopelvic fascia. This is the arcus tendineus. It's a condensation, and you've seen this during radical prostatectomy. And the endopelvic fascia you've seen in radical prostatectomy. The endopelvic fascia comes from the pelvic floor, is lining the inside of the pelvic floor and the levator ani, coming from the left across the front of the bladder and the urethra and up on this side. Very strong. And you've seen when you're doing a radical prostatectomy, you have to cut through it, either with a knife if it's an open one, or a cautery. And it's good, strong tissue. It's basically a big flat ligament. So that's very important. So the arrows here, that is intended to represent high pressure. So straining, lifting, whatever. And this is intended to represent pelvic floor contraction. So if you think about, who mentioned the guarding reflex? So you mentioned the guarding reflex. So when you cough or when you lift, you use the guarding reflex. So I want you to feel your own guarding reflex. So if you think about what you do when you cough, you take a deep breath, then you close your glottis here, don't you? And then you cough. So I don't want nobody to cough, thank you, but do the first two bits. What can you feel that you're doing? Whose turn is it? Yours, I think. What can you feel that you're doing? Just do that. Take a deep breath and stop at this point. What are you doing?
I'm contracting my chest muscles, somehow making it stiffer. Right.
Your chest. Is that going to help your bladder?
Oh, one of the bladder, okay.
I'm not interested in respiratory physiology today, except my cough. I've got a bit of a sore throat, actually.
Somehow I'm also squeezing my perineum.
Good, yeah, you are. So what you're doing is, and you can also feel you're tightening your transversus abdominis muscle, and you're lifting your pelvic floor. So that's very important. So here, if you look at this, you're contracting your pelvic floor. Now, why is that important for the urethra? Well, it's important because the endopelvic fascia is attached to your pelvic floor. So when you lift your pelvic floor, you lift the endopelvic fascia. The corners of the vagina are attached to the endopelvic fascia. So if my hand is what Delancey calls the vaginal hammock, okay? So that's, my hand's the vagina, attached to the endopelvic fascia here. The, whatever you call this, is the urethra. So in the guarding reflex, what I'm doing is that. This is posterior, this is anterior. I'm doing that so that when the pressure comes down, it squashes the urethra against the vaginal hammock. So the problem, of course, after childbirth, if you've got a weak pelvic floor or endopelvic fascia, when the pressure goes up, instead of that going forward, it goes backwards. And of course, if it goes backwards, the bladder neck and urethra is so close that it pulls open the bladder neck. So all the operations we do for stress incontinence surgery reverse that process. So if we, well, the original was the Aldridge sling. Anyone know about the Aldridge sling? Pass the thing back to the next group. The Aldridge sling, well, you would call it the fascial sling. Okay, well, it's done by a chap called Aldridge, first in the 1920s, and he described putting a piece of rectus fascia or fascia lata, and he put it down between the urethra and the vagina and up on the other side. He wasn't strengthening the vagina in itself, he was providing an alternative. And of course the alternative we're familiar with now is TOT and TVT, which is exactly the same concept. Now, we're falling out of love with that, and we're going to discuss that on tomorrow or Sunday. Colpo suspension does strengthen the vaginal hammock because we stitch the corners of the vagina to the back of the pubis. So that strengthens the vaginal hammock. So you can see that all these mechanisms strengthen the vaginal hammock, so when the pressure comes down, the urethra gets squashed, and the urethral pressure goes up by the same amount as the bladder pressure, hence the patient is still dry. The only operations, of course, that don't obey that principle are what? For stress incontinence. What operations do we, I mean, we don't do them very often, but...
Bulking agents.
Bulking agents, yeah, and artificial sphincter. Okay, so they're squeezing, they're essentially squeezing the urethra. So that's a different mechanism. Bulking agents aren't very good, but artificial sphincter is. And now, if we secured continence, now we can think about voiding. We've said we want urethral relaxation and adequate propulsive forces. Normally that means a detrusor contraction and normal urethral geometry. We don't want a big prostate, a stricture, a stone in the urethra, or a big pelvic organ prolapse which kinks the urethra. So what do we see first? As we've already said, we see pelvic floor and intra-urethral striated muscle relaxation. Probably I've suggested that the inner longitudinal smooth muscle of the urethra contracts, shortening the urethra, because that will help to funnel the bladder neck. And then once the bladder neck is funneled, it's much easier for the detrusor contraction to push out all the urine. So normally we would have a sustained detrusor contraction. As far as we know, the detrusor always has a maximal contraction. If your detrusor doesn't work for some reason or other, then if you strain using your abdominal and diaphragmatic muscles, then you can raise the abdominal pressure and you can push the urine out, provided you can relax your urethra. And of course, we see some patients who can't relax their urethra, and again, we'll be talking about those over the weekend. So we're not going to talk, I won't be seduced into answering management questions today, and I don't think any of the faculty will either. So this is what we expect to see. So this is a multi-channel recording in which we've also measured urethral pressure. So there's urethral pressure, abdominal pressure measured in the rectum, bladder pressure, detrusor pressure, and urine flow. So this is the micturition, and this is a normal patient. So here we've got the pressure going along. This is a female patient. The pressure going along at about, 60 centimeters of water, and then at this point, the pressure falls to 0 as the patient decides to void. So if you look at this point here, what's the detrusor doing at this point here? Nothing. The detrusor starts here with, quite a slow increase in pressure. Has flow started at this point? This is the detrusor pressure on its own, and flow only starts at about here when there's sufficient detrusor pressure. So again, emphasizing the first thing is pelvic floor and urethral relaxation before a detrusor contraction can be seen to be started by measuring the pressure. Okay, any questions on anatomy and physiology? Oh, that's good, we're doing well. Any questions on anatomy and physiology? Is everybody happy about that? This is actually a famous house because this is the family house of Bright. Anybody know why Bright is important to us? Well, Thomas Bright was, he was born in this house, so it was his family house, and he was one of the first nephrologists, so he described nephrotic syndrome. This is in the 19th century. And this is where I did urodynamics, in this hut here, in the beginning, and you see these wonderful old cars. But also what you see is the English gentleman's garden, where they, as a question of prestige, they imported all these plants from India, for example. So this is a cypress of Lebanon, so that by definition comes from Lebanon. And this tree here is a ginkgo tree. You know the ginkgo tree? It's a very, very primitive tree which comes from, you don't have them in India, I think it comes from China, which has a strange leaf which looks like two fans. Very primitive. So this, presumably they planted these, and then all their friends, when they came, they would show them around the garden. Well, this one comes from China. This one comes from South America. It shows very cool. Has anyone read Amit Ghosh's books? Amit Ghosh is Indian, yes, and he wrote about the opium trade. And he'd written a trilogy of books. The first one is called Sea of Poppies. You've read it, have you? Fantastic book. And in that, there is a character an Englishman, who has a boat, and he goes to China, and he gets all these plants, and he brings them back to England in this boat, all sort of on the deck, all these trees and what have you. No, you should all read it. I mean, it's fascinating, and it just shows what a positive contribution the British made to India, doesn't it? They ruined the Indian economy in the 19th century, and they stopped all normal agriculture in West Bengal so that they could grow poppies and sell opium to the Chinese. So they made all the inhabitants of West Bengal opium addicts, and they tried to make as many Chinese, and it was the beginning of capitalism really, because it was run by the East India Company, which you all heard of, haven't you? By Calcutta. Is anyone from Calcutta? So you know all about the East India Company. So they defended this practice, which clearly was completely immoral, and there were lots of people in London who didn't like it. They defended it as free trade, and everybody had the right to do free trade, even if it was completely immoral. It was still a God-given right that there should be free trade. And that, of course, started the Opium Wars, etc., etc. So, no, I would recommend you all read it. It's extremely good. So, I digress. Give you a break. So, we need to just think a little bit about patient assessment, history, physical examination, all the stuff you know very well. I keep expecting this machine to work on here. History, I don't need to tell you about that. Bladder diary. How many of you use a bladder diary? Fantastic. Brilliant. That wouldn't be the case if I said laxus written in Europe. So, gentlemen at the back, how would you analyse this bladder diary? So what's this man? I think it's a man. Oh yes, it is a man. How do you know it's a man? Anybody?
Yeah.
Pardon? What did you say?
He drinks beer in the dating.
Oh no, all women drink beer. No, you're quite right. Yes, odds on it's a man because he drinks beer. The person drinks beer. Not many women drink beer. They might drink a bit of lager, but not beer. Yeah, so it's a man. What symptoms is he complaining of? Well, I have to just tell you a little bit about the. We'll be dealing with this again. This is the only validated diary that exists, which is one that we developed. It's one of the ICIQ questionnaires. So this is, you can see this is day 2, there's another day, day 2, day 3, 6 in the morning till 5 o'clock the next morning, 6 in the morning to 5 o'clock the next morning. The amount that's drank, what they're drinking, same urine output. Now 3 is, this is a scale of urgency. 0 is, I didn't need to go, but my mother told me to go because we were going on a long journey in the car and she wanted me to empty my bladder. Well, you all know if you've got children, children can never do that, they can't be bothered. But social void, in other words. And then 1 is a normal void, 2 is I needed to go, 3 is urgency. I felt that I needed to go now. In other words, I feared that if I didn't go now, I would leak. And 4 is I leaked before I got to the bathroom. So you can see this man would have been complaining of urgency. Okay, what else would he have been complaining of?
He seems to have a good frequency.
Frequency, yeah, so he's going, so when he gets, from when he gets up, 1, 2, 3, 4, 5, 6, 7, 8, 9, well he says he goes to bed then, so 9 times.
Nocturia, the diet, I think about 4 to 5 times.
And nocturia,
Yeah.
1, 2, 3, 4. He says he woke at 8, so 5 times.
So that's a lot.
Okay. And what's the diagnosis? Well, we said he's probably got detrusor overactivity because the correlation between urgency and detrusor overactivity, meaning urodynamics, in men is very good. So he's apparently not using pads. So this is quite useful in patients who are incontinent. So it seems that he was dry. But what do you think about the night time then?
Nocturnal polyuria.
He's got nocturnal polyuria. If you had, remembering that you don't include the last void. Now, so in theory you include that void, so what's that? That's 900 mLs. You also include that void, so that's 1100. He's produced 1100 mLs of urine at night. We haven't got time to add all that up, but probably that's about the same. So he's beyond a third of his urine production is at night. So yes, so doing a bladder diary is vital in managing patients, and we'll talk about that at length.
So can I ask one question? In the 3-day diary, which day you choose to calculate your decision?
I'll just look at all of it. Yeah, I mean, you use a 3-day diary to get rid of variability. If you just do a 1-day diary, well, you'll see in a 3-day diary sometimes one day is quite different from another day, but for obvious reasons. You know, maybe they live in India and they went and played tennis one day, and they lost 2 litres of fluid while they were playing tennis. Well, they have less frequency, so it's not quite the same in England, but you can still see quite marked differences. So you're looking at the average, really. Now, most patients are really good at it. And even this chap who came in at 11 in the morning into the clinic and smelled, I think not of beer, probably of whiskey, I'm afraid, at 11 in the morning. That's a bad sign, even in England. And you can see that he had a bottle, and he's measured very carefully the level that the urine came in the bottle. So even though this man was not really mainstream society, he was a bit of an outlier, if you know what I mean. He gave us some good information, 1, 2, 3. He even marked here when he presumably forgot his bottle, 4, 5, 6, 7, 8, 9, 10. So he was getting up, he was going 10 times during the day and then getting up just once. So whiskey's quite good for keeping you asleep. I don't recommend it though, not for a working person. So we find that patients are very good. And there is actually, I use this as a management tool. If the patient doesn't complete a bladder diary when we've asked them to, I say I cannot manage your problem unless I understand your drinking and voiding pattern. So I need you to complete this. Here's your chart. I've done your urodynamics. When you send your chart back to me, I'll write to you and let you know. And do you think he sends it back to me? No, he doesn't. Because he couldn't be bothered to fill in the chart in the first place. And now he can't be bothered to do it again. What is your chance of being able to treat that person? Bearing in mind we're going to ask them to do fluid restrictions, pelvic floor exercises, bladder training, no chance. So it's a very good way of managing patients. You don't waste the patient's time trying to make them do things they're not prepared to do, and you don't waste your own time. What we would call flogging a dead horse. I'm sure you understand the analogy. So bladder diary really critical in managing patients. I think we've come to concentrate a lot more on impact and quality of life, which is sort of a bit like this. If he'd been that bothered about his urinary symptoms, he would have filled the bladder diary in, especially after I'd explained to him how important it was. So the chances are also he probably wouldn't take the tablets if we said, you've got overactive bladder, take some tablets. But if you have an impact on your quality of life, then you're going to do something about it, aren't you? If the patient says, well, yeah, I've got these symptoms, but I just carry on, it doesn't bother me, then that's fine. And we don't normally want to aggressively manage somebody like that, because there's no point. We're dealing mainly with quality of life issues, except as we'll see in children and in neurological patients, we have to look at things slightly differently. So then we think about baseline testing. Examining the patient, yes, I put this slide in because I think it's a very unusual slide, and it's to remind me to say to urologists that if you look after women, you've got to examine them properly. And actually, the gynecologists make a good point that if you're examining for prolapse, you should be examining the patient standing up. The gynecologists do that, and we tend not to do that. And that's important because it's no good you doing a good operation for stress incontinence, and then the patient comes back at 6 weeks and says, and you say, how are you? Are you dry? And the patient says yes, and they look a bit sort of, is there anything bothering you? Well, what about this lump, doctor? And you failed to detect that they had a prolapse, which should have been dealt with at the same time. So I think that's a critical issue. In men as well, occasionally we get somebody sent up for flow studies, has a poor flow, and we find the patient's got a phimosis. So the GPs don't always examine the patients as well as they should do. Urine examination, every patient nowadays gets a dipstick. Do you use dipsticks all the time? Do you send urines for microscopy?
Microscope.
Gentlemen with the term, what's your process for testing for urine? What do you do?
Usually for microscopy we send patients.
You send routine microscopy. Yeah. It's very expensive in England, at least. Do you
Not
do
so
the
much.
microscopy yourself?
No, sir.
No, I was very impressed when I spent a very short fellowship at Stanford in California, and in the clinic, the residents all did microscopy. Now, I thought that was a really good idea. I wouldn't have wanted to do it, but actually it was a really good idea. They really learnt a lot. Because what are we looking for? Well, the other thing, do you ever look at the urine?
Rarely.
Well, that's really useful, because if a patient comes in and you think there's a possibility of infection, ask the nurse, can I see the patient's urine? Now, if you hold the urine up and it looks like tea, weak tea, in the sense there's nothing floating in it, and you can see through it, but it's a nice pale yellow colour, what's the chance of that person having an infection?
Not much.
Percent I want. I want an authoritative statement on percentage. What do you guess then?
3 to 5%.
Pardon?
3 to 5%.
5%. Yeah, it's lower than that. It's an extremely good test. It has to look yellow because what do some people who've got a urinary infection do?
Drink a lot of water.
They drink a lot and it looks like water. So if it looks like water, that's no good. That fails the criteria. It's got to look, I would say to English people, it looks like lager beer. Clear and you can look through it. It's very reliable. Now, if there are bits floating in it, doesn't necessarily mean they've got an infection. It could be phosphatic debris, etc. But that's a useful thing if you have patients. Sometimes somebody will come into the clinic when they say, I always have a urinary infection. But they don't really. Well, not usually. That's not common. And so that's quite a good test to get them to do that. So in the clinic, look at the urine. Get into the habit of looking at patients' urine. And then, of course, the dipstick looks for leukocytes, nitrites, and blood. And only if those are abnormal do we send the patients for microscopy. And in fact, the lab will turn us down. They'll refuse microscopy unless we give a good reason to do microscopy, because it's a cost issue. So we're looking for white cells, red cells, and neoplastic cells. Anybody, what sort of cells are these?
Leukocytes.
Hmm? Sorry, I didn't hear you.
Neutrophils, the small.
Yeah, white cells, okay. So what condition has the patient probably got?
Pyuria.
See, most of you didn't know, whereas if you've been a US, usually when I ask this question, most people don't know. So don't be embarrassed if you don't know. You've forgotten what these things look like. Anybody know what these are? Yeah, shedded urothelial cells. Yes. So we all drop off urothelial cells. That's okay. Nice and normal looking. People usually don't know what these are in the certificate courses. They're not as clever as you lot. That's true. What are these?
Mostly RBCs with some some white
So
cells.
what condition are we thinking about here?
It's got hematuria cross.
I can't hear you.
Hematuria.
Yeah, what condition are we thinking of? What do we want to exclude?
UTI.
No, bladder cancer. Bladder malignancy. Malignancy.
Bladder cancer and
UTI.
stones, yeah?
Stones.
Yeah. So what are these?
White cells.
Yeah, white cells. It's blood we're allowed to have. So sometimes we see patients where there are a lot of white cells and red cells. What's that likely to be? A lot more white cells in this field.
UTI.
Hemorrhagic cystitis. So if you talk to women, quite a lot of women will say that when I get a urinary infection, for the first day or so, I have blood in my urine. So you'd expect to see a lot more white cells. Again, these are all spun down urine specimens. What's this? Transitional cell carcinoma, isn't it? Is it this high grade or low grade? High malignancy or low malignancy?
High grade.
High malignancy, yeah, because the cells fall off, don't they? So lots of weird looking nuclei. So once in a while we'll have a patient who doesn't have hematuria, but in fact cytology, we get a phone call from cytology, who's Mr. Smith? No idea. It's look him up, because he had lower urinary tract symptoms and his urine has been passed from microscopy to cytology. In that sense, he must have had a bit of hematuria, otherwise he wouldn't have got the cytology. Radiology. Is radiology indicated in patients with LUTs?
Not always.
Not
always, based on his physical
Not
examination
routinely.
history.
Good. No, it's not indicated routinely. But of course, if the patient has hematuria, you may find, and this was a lovely old lady who came to the clinic who just complained of increased frequency and getting up at night. She had this huge bladder stone. We had to take that. In those days, it's quite an old picture, we had to take it out by open surgery, and she was then fine. What about endoscopy? Are these two gentlemen at the back part of our team?
Yes.
Can you pass the thing over there, please? Microphone. So what about endoscopy? Is that indicated?
Not routinely.
No. Good, I agree. Well, you remember that was another Euromyth, and you may even have a senior chief where you come from who says, well, I always do a cystoscopy in stress incontinence. Why? Well, because the urethra looks wider. I always do endoscopy in a man with prostatic obstruction. So when I trained, originally as a very young doctor, patients were assessed for prostatectomy on the basis of an IVP. Nobody does IVPs, I think, now. IVP and a cystoscopy. They used to look and say, that's an obstructing prostate. So that was shown not to have good predictive value. So you're quite right. But again, if there's blood in the urine, we're going to maybe see a transitional cell carcinoma or a bladder stone. So only once we've done the basic assessment are we going to advise urodynamics. And then I've sort of divided it up into simple. I'm not really sure whether we should call uroflowmetry and ultrasound assessment of residual urine, whether you should really call that urodynamics. Maybe we should, maybe we shouldn't. And then filling, basic filling and voiding cystometry, complex urodynamics, video and urethral function study, and then advanced. So this is a bit of a semantic argument about the words. So first of all, everybody these days gets uroflowmetry, even the women. And we'll discuss again the importance of that tomorrow. But what we realized many years ago, you will remember there was something called the AUA symptom score, and then there was that was moved, had its name changed to the IPSS, which you all know about. And then, oh, what's his name? It'll come to me. A New York urologist at a fundraising event on a Saturday afternoon when all these people, all these patients and relatives were coming into the hospital for a fundraiser, he gave the IPSS out to everybody, male and female, who just came through the door, patients and non-patients. And surprise, surprise, the women had exactly the same symptoms as the men. So it's rather unfortunate that it's called the International Prostate Symptoms Score, because it has no validity in diagnosing anything to do with the prostate. So the important thing is that women also have voiding problems, and we'll discuss that on Sunday. So increasingly we will do uroflowmetry in women as well as in men. Formerly we only really did them in women. And in fact the gynecologist, I can remember, didn't do any voiding studies. So they would actually go to the trouble of filling the bladder to look if the detrusor overactivity, and then they wouldn't bother to record the voiding phase. But now, of course, we know that that's important. So a normal flow, you all know, and you can all recognize the terrible flow. But of course, the problem is that quite a lot of flows are in the middle, and you don't really know what that means. So it's a great screening test, but it lacks specificity. So most of the patients that we see, 90% of the patients we see, can be dealt with by basic urodynamics. So what we're going to talk about for the rest of today, apart from a short talk again, is basic urodynamics, because that's all you need in the vast majority of patients. And this is a very ancient slide, as you can see, and what we're looking at is the normal patient who has no real change in pressure from empty to full, that's 400 ml. Some patients who have this irritating awareness of bladder filling, who say, I have to go all the time. And it's not because they're going to leak or anything, it's just that their bladder is annoying them, they feel they need to go, and the only way to get rid of that feeling is to go and pass their urine. So they have we call that the hypersensitive bladder, and it has a capacity of less than 250. But of course the common abnormality we find are involuntary detrusor contractions characteristic of detrusor overactivity. Now, in terms of a storage phase, as I've said, filling cystometry is the main test. Urethral function studies during filling Well, we do them at capacity, where we look at urethral pressure profilometry and lead point pressure, and we'll discuss that last thing this afternoon. What's this? This is the classic gentleman there. How would you describe this? What abnormality would you see? Do you, just to explain colours, as you deal in the English language, blue is for bladder, red is for rectum, and green is for detrusor. Okay, and this represents the amount the bladder's been filled. So the bladder's got, that's a scale of 0 to 600. Bladder's got 350 ml. What abnormality does it show? Well, you're here to learn, so I don't expect everybody to know. If everybody knows the answers to everything, anyone? Detrusor overactivity. Okay, nothing's happening in the rectum, and you can see there are these waves of involuntary detrusor contraction, characteristic of detrusor overactivity. So that's the common abnormality we see during filling. And then when we come to the voiding phase, and we're now talking about the voiding phase, flow studies give us an idea about voiding. There are good screening tests that tell us whether the flow is normal or low. But pressure flow studies is a diagnostic study. And in terms of urethral function, well, you can look at the sphincter, but only really by looking at pelvic floor EMG. And of course, as I showed you, the pelvic floor is not connected to the internal, the intrinsic urethral straight muscle sphincter. So that's very much a proxy for what's happening in the urethra. And probably it's true that most of the time it's the same, but not necessarily all the time. And so here we have a classic pressure flow study with very high detrusor pressure and very low flow. So high pressure and low flow gives us the diagnosis of obstruction. Now, if we can't manage the patients, the 90, maybe the 5 or 10%, then the next things we will go on to are video urodynamics. In fact, we're a bit strange in Bristol because we do urethral function studies on everybody. We can talk about that later on. So video urodynamics, that can be very useful. Now this is a female patient, so you can, whoops, sorry. So you can see here, this is the bladder. This is actually the bladder neck, and this is the urethra. So this woman had high flow and low pressure, high pressure and low flow. So on flow study, she had a poor flow rate, and we wanted to find out why. And she's in fact got a narrowing at sphincter level for unknown reasons. She was neurologically normal. So you wouldn't know that unless you did video. So this is slightly different, but it shows that video is important when you need anatomical information together with your urodynamic information. So that's the importance of video. And then urethral function studies, as I said, we'll talk about later. In a very tiny number of patients, we still don't know what's wrong with the patient. And this is Sue, one of our technicians, who's modeling the ambulatory urodynamics, and you can see that she's wearing, this is in fact a computer she doesn't actually have catheter in her because she didn't want to have that. That was no point. So normally you would have a urethral and a rectal catheter in to measure pressure, and then a pad which senses urine loss, and then you send the patient off to do whatever. And I had a patient, and actually somebody told me about, they had an identical patient the other week. We were in some meeting or other, and this was a very good tennis player, and when she went to do overhead smashes, she leaked. And this was a matter of some embarrassment. Well, she was very worried about it, as you can imagine. She was a youngish woman, and if you had to, you could send somebody onto the tennis court with this, which you can't obviously do with regular urine. It's strange with this big machine following you around the tennis court, wouldn't be practical. So you can look at these difficult problems. Well, we act as the regional referral centre. It's complicated and it's not difficult to do, but it's difficult to analyse. So you need some sophisticated measurement and very good staff to analyse it. And then neurophysiological testing, well basically we really don't do any. We have done a little bit of sphincter EMG, and we'll talk again about that on Sunday. But if you really need to do this, nerve conduction studies are best done by neurophysiology, not done by neurology. And the same with reflex latency. So if you work with a neurophysiologist or a neurologist, then they can do these studies for you. So let's get back to simple. So I like to talk about the 4 diagnoses of urodynamics. So when you do urodynamics, I expect you to give me a report which gives the four diagnoses. So what does the bladder do during filling? What does the urethra do during filling? What does the bladder do during voiding? And what does the urethra do during voiding? Well, we've defined what it should be doing. Therefore, the only abnormalities that you can have are the opposite. So that's how simple, really, urodynamics is. So in other words, if we can define normal function, we know what abnormal function is. Therefore, abnormal function of the detruser during filling is that it's overactive. It can't be underactive because it's supposed to be relaxed. So the only abnormality is detruser overactivity. The urethra is supposed to be competent during filling. Now, of course, patients with normal urethral function can leak during voiding. So what normal patients can leak during voiding? Sorry, they're not normal patients. What patient with normal urethral function may leak during filling?
Normal urethra with
normal urethral function. What patient with normal urethral function may leak during filling during urodynamics and real life? Patients with detruser overactivity. Okay, so the fact that you have urgency incontinence doesn't mean there's anything wrong with your urethra. Remember, normal micturition reflex is urethral relaxation, detruser contraction. So some people used to talk about detruser overactivity as a pre-micturition reflex, which is sort of logical. So, but generally, we expect urethral competence. So certainly in terms of stress incontinence, you would expect to describe the urethra as incompetent. And then if we turn to voiding, the only abnormality you can have with the detruser is that it's underactive. It can't be overactive during voiding. As far as we know, the contraction is a maximal contraction. So it can be underactive during voiding, and sometimes it can be acontractile, just doesn't work at all. And during voiding, of course, the urethra should relax, so the only abnormality you can have is that it obstructs voiding. So that's why I say that these 4 diagnoses are really simple. And when you write your urodynamic report, you should say something about each of these 4 components. Now, as I've said at the bottom, it's not really 4, it's say 7. Because you also would like to know about bladder and urethral function, sensation. You also want to know how big's the bladder, what's the maximum systematic capacity, and you want to know what's the post, actually I shouldn't put equals 7, because it looks like post-void residual equals 7. No, so it's really not 4, it's 7 diagnoses. And of course the reason we do urodynamics is because some patients will tell us that their urine flow is really poor. When we measure it, the urine flow is fantastic. Another patient will tell us that their urine flow is fantastic when it's really not very good. That's rather more common, particularly in older men, because of course prostatic obstruction comes on very, very slowly, and many older men will tell you that their flow's okay. But it's not actually compared with what it was 20 years ago, but they've forgotten what it was 20 years ago, and most men don't particularly care if their flow is a bit slow. if it takes them an extra 20 seconds to void, well, you know, as long as you're retired, it doesn't really matter. So symptoms are not reliable, hence urodynamics. Good, thank you very much. So, any questions?
I want to ask in older men.
Pardon?
In older men,
Yeah.
if there is a low flow, but since the upper side is always normal, everything is normal, but there is only low flow. So whether we should treat him or should, there is no other symptom in the patient. IPS score is absolutely normal, but there is only low flow in the urine.
That's clinical. And it's nearly coffee. We'll be covering that tomorrow. Any other technical issues you want to discuss?